Hello, everyone. We're ready for another Live with CCO. So happy to have you with us. Very excited. We are on episode 101. Episode 100, by the way, was a discussion on the table of drugs and chemicals. What a hit. So fabulous. Therefore, we had a suggestion come in. Can you review the neoplasm table just like you did the table of drugs and chemicals? Absolutely, we can. I love the neoplasm table because I'm all about diagnoses and the disease process, and there is so much going on when you have a patient that is a cancer patient. So today we'll be looking at the neoplasm table, how and why it's used. Got some insight for you if you're a student, how to navigate the neoplasm table. But don't worry, let's say you're not a student. Let's say you're pretty seasoned. I also added a few tips that might be helpful for you to, in addition, tell your students or your colleagues to make it a little easier navigating the neoplasm table, but most importantly, getting to the correct diagnosis code for your cancer patients. It's all about the specificity, and we're going to explain why that's so important. I'm always saying, you guys can probably quote me now, but I always say we code for statistical purposes. It happens to be a convenient way to get paid. That's the way we should always think about it when we translate the provider's documentation. We are translating into a format that can be captured for statistics so that we can follow a disease process, find out what treatments work for specific diagnoses, and in turn track not only in our health community that you're practicing in, but also it happens on a global standpoint. Let's see here. Let's talk about neoplasms themselves. We've got to get to the basics. Let's decide what's your knowledge base on neoplasms. And neoplasm ultimately has multiple terms that it can be used. It can be a mass, it could be a tumor. A neoplasm does not mean that it's automatically cancer that's malignant, that somebody has to go in and get chemotherapy and lose their hair, or they might die, etc. It goes from a very narrow scope to a very broad scope. So that's why it's called a neoplasm table, not a cancer table. Or it could be, abnormal cell table, I guess it could be any of those things. Neoplasm is a common term, but when you look at documentation, you could see it as a mass, a tumor, etc. Neoplasm is, for a better word, a benign term. It can mean many things. And also, we need to remember that unlike normal cells that really follow a regulated pattern in growth, whenever it can be classified as a neoplasm, we have uh, division that is abnormal. We have the cells not working in the program the way they were programmed to work, and they have lost their ability to control how their growth and division. Ultimately, it develops in a mass of cells that don't conform to what they're supposed to be doing. And if in some instances it becomes malignant, that means that it decides to spread. Uh, both benign and malignant cells can be invasive. However, and they both can be life threatening. But the difference between benign and malignant is that benign it stays in one place. Uh, it doesn't mean that it doesn't get invasive, but a benign growth on your forehead is not going to end up in your colon. It's going to stay here. Um, is that mean that it's going to complicate things? Absolutely. It can get down and cover your eyesight. It could grow so much that it shuts the airway off in your nose. Think about if a location is very important. So, a benign growth of cells um, in the lung next to your heart is going to compromise the structure and the ability for both the heart and the lungs to be able to do their job. Excuse me. I have to get a little sippy of water. Mm. All right. Excuse me. I get so excited about what I want to tell you about. Plus, I don't know about you guys, but it's hot out there. Tell me where you guys are from. I see Kentucky, Bronx, New York, of course, Carmen, woohoo, New Jersey, Washington. I would think that it's a little bit cooler in Washington right now, on the oh, but if you're Eastern Washington, not necessarily. From what I understand, that's real sandy. Florida, and I see names I recognize too. Houston. Oh dear. Huh. Mr. Martin in Houston. Bless your heart. Alabama, Pittsburgh. Mm. Hazard, Kentucky. That's where they did the Dukes of Hazard. North Mississippi. Odessa, Texas. Woohoo! I used to live in San Angelo. So Odessa's I know Odessa, Midland and Odessa. All right, guys, great to see you. Um, let's get back on track now that I may have to take lots of drinks today. Some of the areas that we need to focus on about understand neoplasms again, uncontrolled growth, invasion, autonomy, blood supply, lack of differentiation, and malignancy. I'm going to go and break these down because, again, some of you are more advanced and maybe not newcomers, but if you are newer to the code set, I want you to understand how neoplasms work. This will also assist you in understanding not only the disease process, but how the table will come together. Mm. Mary Ann from Nebraska. All right. And Wyoming. Woohoo. All right. I said all right more than once. Sorry. Uncontrolled growth. Anything that's abnormal is going to cause complications in the body, whether your heart rate's abnormal, whether it is the digestive tract not emptying out or getting rid of waste like it's supposed to. Uh, your body was created to work in a perfect manner, hemostasis, everything working like a well oiled machine. However, if you get a clump of cells that decide that for whatever reason they're going to grow faster than they should, or die slower or faster than they uh, should, what happens if your skin cells don't die and slough off? Well, then you're going to start getting skin that has the consistency of elephant hide, right? Uh, that's not good. That's a problem. So again, our growth of our cells everywhere in the body, they have a specific time where they split and grow and a specific lifespan. And we've studied it for so long, we know the lifespan of a hair cell, of a heart cell, of a gastric cell, to the alveoli in your lungs, your fingernails. We know all of that. Autonomy is the when the cell itself has a cellular regulatory mechanism that goes to unchecked growth. And so it's a neoplastic cell. Lack of differentiation, that is when the cell doesn't look normal. Do you remember back in school biology, you got to look at the slides and they gave you a slide of a plant cell and they showed you the difference between a plant cell and a human cell. Plant cells are square, human cells are round. Plant cells are square, then stack on each other. That's how they get their structure. And that's how they pull fluid is going up, kind of like a ladder. So there's a rhyme and a reason as to why they're made the way they're made. Whereas a human cell is round, and that human cell has to be able to move fluidly a lot, and the fluid, the way that it replicates is different. There's a lot of differences, and there's just a lot of similarities between a human cell and a plant cell. But the number one thing is that its structure is different when you look under it aside. It still has a nucleus and all the other things. What would happen if some of your skin cells started, one came out square instead of round, and then it split and made two more square, and then those split, and then you have four, then you have eight, then you got, so it multiplies. Well, most of the time, if we have an abnormal cell, whether it's due to a chemical contact, an injury, whatever, it dies off and it doesn't replicate itself. It's been injured and it's okay. But lack of differentiation is when you start getting these cells that have different um, body types, and they call that anaplasia. And you can see that when, and they can say right away, oh, that cell doesn't look right. Uh, Also, malignant neoplasms are invasive. Now, benign, when we say invasive, benign cells can be structurally invasive, like I said, having a tumor on your forehead that continues to grow until it obstructs your vision, your ability to breathe through your nose, and it's probably growing inside as well as out. And the only thing that's preventing it from smashing your brain is the fact that you have a skull. Uh, but malignant neoplasms, when they say invasive, that means that they start in one place and they go someplace else and start replicating abnormal cells in a different part of your body. So if you have a tumor on your forehead, instead of it can grow there, but when they do a biopsy of that tumor and or that mass, and they look at the abnormal cells that it's creating, and then they find um, another part of that cell in a lung biopsy, and they say these skin cells are in your lung. That's not good. Again, you've got skin cell in an area that should be lung cells, so they're doing skin cell things in a lung cell area. That is invasion. The blood supply. This is really interesting, and a lot of people don't realize this about neoplasms. Neoplasm can stimulate growth of new blood vessels, which is called angiogenesis, to supply nutrients and oxygens to rapidly dividing cells. If you didn't know, chemotherapy kills rapid growing cells. That's why it's used to treat cancer. Neoplasms that are malignant are rapid growing cells, and they're abnormal rapid growing cells, and they like to go places. So what do? They poison the entire body with a chemical that will kill rapid dividing cells. That's why you lose your hair, because the hair cells are rapid growing cells. Your digestive tract, the inner lining of your digestive tract, rapid growing cells. They slough off faster and die faster than other parts of your body, like your fingernails. Well, a tumor that's a neoplasm that's malignant can grow its own blood supply. That is a problem. Malignancy is I don't want to say it's the opposite, different than benign neoplasms or masses, because they're generally well controlled. There's still doing their job in their area, they're just usually not dying when they're supposed to. That doesn't mean eventually they can't turn into malignant. That can happen, but most of the time they can get in there and get rid of them before they get to that stage. But malignancy is not contained, and it will invade nearby tissue and metastasize. So a tumor here, if it wasn't benign, it can end up in your brain. Because the cells are so close to your brain, and it likes to float around your blood and lymphatic system. Uh, then it starts messing with your brain cells, and you don't want skin cells in your brain either. We have to be aware that neoplasms are classified based on their behavior. So we have benign and malignant, and the tissue or organ of origin and their microscopic characters. So the pathologist is the one who is going to determine what the cells are, whether they're benign or malignant. That's their expertise, is looking at cells and other types of tissue. Sarah said invasive cells can run wild. Our Mohs surgeon have started with a lesion of 0.8 centimeters, and after several stages, finally, wound length could be 5 centimeters or even needing a graft to tissue transfer. Uh, Absolutely. Mohs surgery has been a huge blessing for determining different types of skin neoplasms, whether they're benign or malignant. But melanoma is extremely invasive. It is malignant, and it likes to go everywhere in the body. And we don't talk about it a lot. People die of melanoma. You don't think of dying of skin cancer, but that's ultimately what it is. And you're right, they can get in there and start digging. But in the past, they had to cut a huge hunk because they wanted to make sure they get all of it. And that's what they would do if they were, say, taking malignancy off the breast or even the lung. They'll take out the whole lung. But with Mohs, they used to take a big hunk and deep, and then you have to graft all of that. But now they can do a specific surgery for it, which is called Mohs surgery. And we have done a lot of education on Mohs surgery. Once it clicks in your brain, it's much easier to code. Otherwise, it's a little intimidating for the first time. So we like teaching Mohs surgery. Now, the neoplasm table, it's a tool. It just makes it easier for you to find the code that you need at the highest specificity. We could go to the index, just like before, but there's so many neoplasms. It takes up a huge area in the index, and the neoplasm just narrows it down. It's going to allow us to get to the highest specificity quicker. They have a lot of reasons why we would use it, whether it's just looking at the medical documentation and getting proper billing, and they use it for research and epidemiology as well. If you get into really liking cancer coding, then you might want to look into tumor registry. Heads up, a lot of people that did that for years and years are starting to age out and get to the retirement age. And there's not a lot of up and comers that are willing to take that on. And it's very similar to medical coding. The codes, again, somewhat the same, but they have a little bit different role, and education is a big part of what they do. Let's talk about the table structure of the neoplasm table. There's a hierarchical structure, and it's all done alphanumeric, which really it's just alphabetical. It's not really alphanumeric, but it is alpha and numeric once you get past the first character. There's categories and subcategories, and there's four main axes of classification. The first thing is it benign or is it malignant? And site or origin affected. It's all about the body part. Then morphology of the tumor and laterality can be included. Now, here's an example of looking up a particular type of cancer. You would go to the neoplasm table and look under breast. And I'm gonna tell you a little bit more about breast cancer in a moment. This would include connective tissue, glandular tissue, or soft parts of the breast, and then you can narrow it down to different uh, um, quadrants of the breast. But this one code is for midline. Now, whenever you see a code that under midline, it says C50.8, um, and then a hyphen. That means there's more characters in the neoplasm table, so do know that. I looked up malignant, so that's why that's in yellow. And when I did the copy um, of this, if it's a neoplasm and it's unspecified, we don't know anything about it, that would be, and we don't have location, that is C80.1. You can find that information in your guidelines for malignant primary. Midline, though, is C50.8 with additional characters. If it's secondary cancer, that's C79.81. If it's cancer in situ, D50 point, more characters. Benign is D24 point, more characters. If it's uncertain behavior, D48.6, more characters. And unspecified behavior, D49.3. Um, I'm going to tell you what each one of those mean, but the point that I want to get across showing you that aspect of the neoplasm table is that we have a body area, specific body area located. There are a lot of codes for breast cancer because of location. And uh, even uh, laterality can be involved. But look at the next one that I took an image of. We have neoplasm of the lung, lower lobe. If you don't know the anatomy, we have lobes in our lungs. There's more lobes in one lung than the other. One has two and one has three. Why don't you put in the chat which side has three lobes, the left or the right? But this is lower lobe. And then the code for malignant primary is C34.3. But those other characters will use the laterality. That's why there's a hyphen there. C78.0 is malignant secondary. Cancer in situ, D02.2, benign, D14.3, uncertain behavior, D38.1, and D49.1. Sarah was the first one to announce that it's the right lobe. Sheena is the second one. Very good. There's three on the right and two lobes on the left. We don't know why, but there is. All right. All right. All right. All right. I get so excited to keep going. This gives you an idea of what the neoplasm looks like. We have where the cancer is located, or the neoplasm, and then specificity as to a specific area within that body part. And then we have to go to the right and determine, did the provider say it's malignant or benign? If it's malignant, we have to ask ourselves, is it primary or secondary? If it's benign, we're good. We can stop there. Cancer in situ is malignant, but it's a specific type of encapsulated malignancy. It doesn't metastasize like primary and secondary malignancies do. Primary means it's the first place it's been located. However, it also means that it's in that body area. If you have a mass in your lung, they do a biopsy and they see that it's lung cells that have become abnormal and are growing at a rapid rate. That's primary lung cancer. If they go to your colon and find a mass and they biopsy it and it's lung cells, that's secondary colon cancer. okay, because it came from the lung. The lung cancer metastasized to a new location, and that is a secondary location. All kinds of rules about that in the guidelines. We've done a lot of education on that, so I don't want to get tied up on those specifics uh, as we just show you how to use the neoplasm table. Uh, Once you look at the neoplasm table and we've determined that we have the right body part down to specificity, the right area. So we have a lung cancer, lower lobe, and in this scenario, secondary is highlighted, but I pulled the code for primary and it's C34.3, you don't stop there because that hyphen tells you there's more codes. You do not code from the neoplasm table. It is a tool to get you to the right codes quickly, and then you jump out to the tabular for specificity. Fill out the rest of the codes. Also, make sure there is no guidelines or specificity within that code description that you need to be aware of. And in this scenario, I gave you a copy of what the index looks like. The neoplasm table tells us primary malignant would be C34.3, but that's not the rest of the story. If it is of the right lung, then it's C34.31. If it's the left lung, it's C34.32. Now, if we are not given specificity as being the left or the right, then we would use C34.30 unspecified. Hopefully, once more information was given, then you would be able to get to higher specificity where the right or left had been identified. There's a time and a place for unspecified as they're just trying to discover what's going on with the patient. Again, you start at the neoplasm table, identify the body part. Once you have the body part, is there any more specificity within the body part that we can narrow it down to via the documentation? And once there is, then we can jump out to the tabular, confirm all of the characters are being applied appropriately because of the documentation that we're given and any rules that we should look at. So what is actually the purpose of these codes? Why are we doing this uh, in the first place? Clinical application and the importance of understanding the disease epidemiology. We do it for billing and reimbursement and claims processing. We also use them for treatment planning and decision making and research and data analysis. All of that is extremely important. That's why I tell you we code for statistical purposes. It happens to be a convenient way to get paid. So on this little table here, billing, reimbursement, and claims processing, very, very important. We want to be reimbursed properly for the evaluation and the management and the treatment that's given to our patients with neoplasms. However, even more importantly, we want to make sure we're getting to the highest specificity at all times because of the surveillance and the disease process. We know how many people have breast cancer in the United States. We know how many people in the States has breast cancer of the left breast versus the right breast. Now, break that down. Let's say we know how many people have breast cancer, primary, of the right breast in the state that you live in. And we can even narrow down it to the county that you live in. That's huge. That tells us what type of treatments and resources are needed in your um, county. And then the treatment planning and the medical decision making. How do we know what is more effective for cancer in situ versus secondary cancer of the breast? Because of the statistics we've captured for the last multiple decades since the code set has started. Uh, then research and data analysis. It's all self-explanatory, right? It's extremely important that we use the tools at our fingertips, the Neoplasm table, and then uh, bounce to the tabular to get to the highest specificity when coding for neoplasms. It's not just about getting paid, it's so much bigger than that. One of the um, best funded resource and foundations for cancer is breast cancer. Can you imagine in the last 50 years what has been done for research in breast cancer? That so much so that football teams wear pink to help, you know, with research. A lot of money is pushed in to breast cancer, and that is why we have even more specificity within the code set for breast cancer. We know how important it is. We're going to talk more about that in just a moment. I want to take a little commercial break. And if you do not know about our CCO club, it's time that you go take a peek and find out all of the amazing things that could be a resource for you in our CCO club. We do CCO lives for you free almost every Thursday. That's free content we give back to the community. And we also let you tell us what we want to talk about. Well, actually, if you let me talk about what I want, then I'm going to always talk about diagnoses, ICD-10, and the disease process. And I really like cancer to talk about cancer. But in our other lectures that we give, they are proprietary and exclusive to our students in our CCO club. We may give you little peeks to entice you to learn our teaching style or insight into some of the things that we have been educating our students on. When you're in the CCO club, you get that exclusive content. You get the lectures that we give. You get to use them as a replay. You don't have to watch them live. You can if you want to, but you get the slide deck, you get the transcripts, and then you get to go in and discuss that content amongst your peers. The CCO Club is extremely valuable as a resource tool. It's simple to find at cco.us/, and we would appreciate it if you think that our education is valuable or would help others, that you tell your colleagues, peers, friends, and family. Again, real easy to find, cco.us/club, where you can get the complete package of education that we give out exclusively to our members. So let's now talk about why specificity is extremely important. And this is kind of a pet peeve for me as an auditor when dealing and most often you'll see it with dermatologists. Uh, no fault of their own per se, in that they just haven't been educated as to the way this code set verbiage definition is set up. But once you educate them, they have aha moments, and they appreciate understanding the difference in something as simple as uncertain and unspecified. If you're a student, you've probably already learned this, and you may have already come across this in your practices where you work. But let's take two different codes on the neoplasm table that are out there at the end and we don't use very often. We use unspecified a lot because maybe it's been a screening and they need more diagnostic testing, more information to get specificity. So, unspecified is a diagnosis that a doctor or a surgeon is going to give to a neoplasm. What we see them do too often is use the uncertain behavior code. That can only be diagnosed by the pathologist. Unspecified within the code set as a standard rule means I looking at it and I don't know what it is yet, or I didn't document it yet. or failed to document it. There's, again, a reason for unspecified. And you send off a biopsy to the pathologist to get specificity. The pathologist looks at it and they will be able to tell you if it's primary, it's a mass in the lung and it's lung tissue. Secondary, it's a mass in the colon and it's lung tissue. That's secondary. Or it's an encapsulated mass in the lung. It's not going anywhere, but it is malignant. That's cancer in situ or CIS. Benign, it's they recognize this cell. It's abnormal, rapid growing cells in the lung. It's not going to metastasize to another location in the body. Or it's uncertain behavior, which is defined as a definitive diagnosis. It means that that particular type of cell could turn malignant or benign. We just don't know, but it's definitive. It is not unspecified. It says, when I see this cell, I recognize it, and it's a cell we got to pay very close attention to because it can go in 2 or 3 different directions as to how it will manifestate itself further. It's defined, it's definitive, and the pathologist recognizes it. Whereas unspecified is never going to be listed under the pathologist because they're physically looking with their little hairy eyeballs. I see what this cell is. It's not unspecified. The only way it would be unspecified would be if they've never seen that cell before, ever. It's an alien or foreign body cell. And even then, if it's a foreign body, they would be able to recognize it and identify it. So the unspecified is used for the provider or the surgeon that takes the biopsy and sends it to the pathologist. Very, very critical that they get this right because we don't want a bunch of diagnoses as uncertain being captured for statistics when in fact the pathologist didn't say that. The doctor or surgeon says that. It's not correct. It would not be the highest specificity. Continuing with specificity, how do we get to the correct specificity? Well, we make sure we understand the code set. We understand the difference between primary malignancy, secondary malignancy, and that can, when you're first learning, it can get kind of wonky in your brain. And cancer in situ or CIS, benign, uncertain, and unspecified. We have to be able to understand those and how the code set works and how we fill the characters to the highest level using all the characters when we have that availability. Also, within the code set, laterality being used, that if it's identified as right or left, then we would be able to use those codes. If there isn't laterality in the code provided, then we use a modifier to state that there's laterality involved. We make sure that we understand the documentation, that we understand the difference in the documentation. And it can get kind of crazy sometimes when the provider states that it's a secondary cancer being treated as the primary or the reason why the patient's being seen, or that the anemia is due to the secondary cancer, not the primary cancer, or when the primary cancer has been resolved and the secondary cancer is the one being treated. We have to be able to understand the documentation and the verbiage. We also have to understand the disease process. If we don't realize how cells work, if we don't understand the treatments that are used for these abnormal cells, medications that are involved, do you know what leuperin is? Do you know what it's commonly used for? What type of cancer? So if you see the patient, if you see documentation that states The patient was seen today for a history of hypertension, diabetes, and prostate cancer. Um, Everything is stable. Continue on Lupron. A refill for their Lupron was given. Well, no, that means first of all, you're don't have a history most likely of those three diagnoses. It could be a history of prostate cancer, but if the patient's on Lupron, that's active treatment of prostate cancer. So we have to understand the disease process and the documentation. Another reason we have to understand this, all three of those bullets, is that primary cancer alone, C50, there are so many nuances. Because it's so heavily researched, the code set has expanded amazingly. And the breast is divided up in quadrants and everything. And we want to make sure that we unpack that and fill every single one of the characters that's uh, possible through the documentation. If you didn't know, and this may blow your mind, but there's over 900 codes to describe primary breast cancer. And the reason that is we have to have the location. We have to have whether it's male or female. Did you know that men can have breast cancer? And we need laterality. So that gives you a really large number just starting out. So the location, every single one that's listed here is a location it's identifiable for a breast cancer code. So if it's the nipple and areola, or if it's the central portion of the breast, maybe it's the lower inner quadrant. So they quad the breast. Because of so much research, we know how important it is to pinpoint the location to determine what is the best treatment for that breast and survival for the patient. Let's say it's lower inner quadrant. So now we have the location. Is it on a male or a female? Well, it's a female. Okay. Now, you see how many codes that we're getting into? Is it the right or left breast? Uh, just crazy. Over 900 codes. And that's primary. That's not secondary. So you add all of that for secondary. And then you start adding for benign and so on and so forth. Now it starts narrowing down as you get into some more obscure types of cancer. But that should be mind blowing to you. And why it's important to have specificity, to understand the code set and understand the disease process, as well as how to read the documentation. Continuing with specificity, I wanted to show you an example of another reason that we need to know those bullets. The example I wrote out just real quick was Mrs. Plum, that's from the movie Clue, by the way, has a new diagnosis of leukemia and has started care with Dr. Hemi in oncology. So, how would you code that? Well, it's leukemia. All right. Um, it's leukemia unspecified. If you didn't know the disease process, there's multiple types of leukemia. And leukemia is a liquid cancer, not a solid cancer. So that sets it off in a unique stage or a little avenue of disease process and terminology. What do you think the first term is in the neoplasm table that you would look at to find leukemia? Okay, it's a liquid cancer, it's a blood cancer. Um, it, a lot of those cancers are divided up and called soft tissue. It's kind of a catch-all. It's a lymphatic system. It can be a gland, and or we could just look up leukemia. Well, leukemia is not in the neoplasm table. So if you try to do that, you're not going anywhere. And if you look up blood, it's not going to give you it's going to give you soft tissue. And if you look up liquid, that doesn't count. That's not even in there. There is gland in there, uh, but the key term is going to be lymphatic because when you go ahead and you look at the tabular, it's divided up into malignant neoplasms with the code range, uh, malignant neoplasms of lymphoid, hematopoietic. That's not really how you say that. and related tissue. Then it narrows it down to leukemia unspecified. And then you see that it further needs specificity is not having achieved remission, in remission, or in relapse. And these are all unspecified types of leukemia. So the code set, we have to know that the code set wants to know, is it in remission or not in remission? And we know that it's a liquid cancers do not they're never a history of. They are in remission or not in remission. Again, you just have to know that. Why would it be important to know the difference between leukemia unspecified versus a specific type of leukemia? And there's multiple of them. Let's say that we just have leukemia unspecified, then not having achieved remission, that would be C95.90. Now, if you are into risk adjustment like I am, and are one of those risk adjustment HCC nuts, you would know that leukemia unspecified risk adjusts as one of the lowest cancers available. But if you have any type of specificity for that cancer, that leukemia, it it more than doubles it. So, C91.A0, mature B-cell leukemia, Burkitt type, not having achieved remission, it goes from a 0.306 HCC of 10 to an HCC of 20 that has a risk score of 1.359. The average risk score for a patient alone is a 1, and a lot of times it's under a 1. That again tells you the importance. So the documentation could have read, Mrs. Plum brought the oncologist visit note, and Dr. Hemme reported Burkitt type cells were noted. Now we go from a C95.90 to a C91.A0. And not only do we have higher specificity, um, but it captured a higher risk score in HCC for that patient so that the payer can budget and set more money aside for the care of that patient. Wrapping up, guys, the main components of what you need to know regarding the neoplasm table is accurate neoplasm coding makes an impact. I hope I was able to show that to you on several levels. Statistical tracking is extremely important. It's why we do what we do. That's why we translate the documentation into a code set. So not only can it go to the payer for reimbursement, but that it can also go globally to capture statistics. So it's twofold. Statistical tracking to me is more important, and also statistical tracking just for your department. How many people have cancer that you're treating? If you have a high number of cancer patients, then you may need an oncologist close by. And if you're in a rural area, then it's important that your patients know where they can get the resources from an oncologist and so on and so forth. Continue to learn and stay updated. The codes change every year. We know that. They tweak and morph a little bit every year, almost every year. Very seldom will you find a year where cancer codes do not have changes, and it is usually higher specificity. To be able to get within the code set that breast cancer, primary breast cancer, has over 900 codes, can you imagine how many times those have been revised and upgraded? And also new discoveries in medicine. That's why we have over 900 codes for breast cancer, primary. Uh, the more researches that is done into cancer, the more codes that are needed to be able to statistically capture the data as well as the reimbursement. Never code from the neoplasm table. All the information is not there. Even if you see a code that doesn't have the hyphen and you think, okay, that's the entire code. No, you have to go out to the neoplasm table to confirm there's no guidelines, there are no excludes in there, that there's no little nuances that tell you don't code this code with another code. And it gives you further suggestions for higher specificity sometimes. And Always trust that index, though, the index and the neoplasm table, because the verbiage may not be the same. That's how you have to trust that when it tells you to go to leukemia, that you get to the right place, because leukemia is not in the neoplasm table. But you look it up by going to the neoplasm table, then you look up the term lymphoid or lymphatic, and then it tells you that you're going to the right code to get you to the tabular, and then you say, yes, I'm in this right area, because you can go up and you look at that slide that I showed you. It started at cancer and it broke it down all the way to the liquid cancer. You have to remember you are only as smart as the people you surround yourself with. So you want to have people that are your mentor or your peers that are uh, there to bounce ideas and questions off of. I have several groups of people that I stay in contact with, and you are only as smart as the resources that you use as well. That's why we promote the CCO Club, to be able to use our resources and to tap into the peers that you and colleagues that you'd find in there. If you have a topic that you would like us to talk more about and offer education in, feel free to send it to us. The best way to do it is cco.us/topic-request. Our students and our CCO Club members always come first. We will look at their suggestions and create that education that they request first. But if you are not a member of the club and or a student, feel free to let us know what you think we need to educate on. Again, otherwise it'll all be what I want, that I get to pick. And please give this link to your colleagues and peers, maybe your instructors, and maybe they are struggling with a particular area that they need assistance with. And we may already have education created around that topic, and we'll let you know if that's the case. But we can't continue what we do if we don't know what you need, and education is our specialty. We enjoy what we do. Actually, we love what we do. And because of that, we hope that you always feel that it's fun to learn with CCO. We can't, again, continue to provide this great education free to you if one, you don't let us know what you need, and two, if you don't share with others and spread the word. All right, guys, really, really appreciate you being with us, and I look forward to doing this again next week. Bye, guys.
Do you need more medical certification and business training? Learn more at www.cco.us.